This is a primary care pharmacology rapid update video all about the use of anastrozole for the prevention of breast cancer. This is going to be a bit different to my usual videos. Rather than being a deep dive into aromatase inhibitors in general, I'm just going to focus on the use of anastrozole in prevention of breast cancer, as this is a topic that's been in the news recently. And a lot of GP surgeries are fielding a lot of calls about it, but unfortunately there's not been much in the way of guidance provided from NHS England or NICE to go alongside it, so I'm hearing a lot of colleagues who are unsure about what advice they should be giving. I'm just going to quickly talk about what's changed and the pharmacology, as well as the evidence base for this change, which patients does it affect, and how should we counsel people on side effects and where they should go from there. First things first, what's changed? You probably heard in the news on the 6th of November, the MHRA has approved the use of anastrozole for prevention of breast cancer in patients deemed to be high risk. Previously, it's only been licensed in the use to treat patients who already have a diagnosis of breast cancer. As I mentioned, there isn't any specific guidelines or criteria for who will qualify for this. Anastrozole, as you probably know, is an aromatase inhibitor. In premenopausal women, the vast majority of the estrogen is made in the ovary. However, following menopause, this shifts and most of it is made in adipose tissue. In order to generate estrogen, aromatase is involved in the conversion of testosterone. Use of aromatase inhibitors therefore reduces the production of estrogen and can be very useful in the treatment of estrogen receptor positive breast cancers. I should point out this will only work in postmenopausal women. If you try and give aromatase inhibitors to premenopausal women, you will just drive their ovaries to produce more estrogen, completely negating any useful effect. The evidence in this change has come from this paper, IBIS 2, that was published back in 2019. The researchers recruited just shy of 4,000 postmenopausal women who were deemed at high risk of breast cancer and randomised them to either 5 years treatment of anastrozole or 5 years of placebo. After a median follow-up of about 12 years, they found about a 49% reduction in breast cancer diagnosis in the anastrozole group. Now, that sounds pretty huge, but what do we actually mean by that when we look at total numbers? In the treatment group, the risk of breast cancer was about 5.3%, whereas in the placebo group, the risk was about 8.8%. This meant the number needed to treat to prevent one episode of breast cancer was 29. This is an important number to be familiar with, and it's probably the easiest way of explaining the benefit of use of anastrozole for this reason when considering whether it's worth it for the associated side effects. I should point out that there were no significant difference in the number of deaths seen in each of the two groups, but there was also no excess fractures seen in the treatment group, which is an important thing to consider when we talk about side effects later on. When we talk about women at higher risk of breast cancer, who are we referring to? And this was defined in the original IBIS 1 paper, which looked at tamoxifen and was published around about 2004. I'm not going to go through this list one step by step, but I will point out that the majority of patients, as you can see, with those who either had a first-degree relative who developed breast cancer before the age of 50, or those who had 2 or more first or second-degree relatives with breast cancer. There were some smaller niche groups there, such as those with pre-malignant conditions, or what I say pre-malignant, non-malignant conditions associated with increased risk, such as lobular carcinoma in situ or atypical hyperplasia. But obviously this will make a fairly small number, and I suspect that most women coming to see you will be concerned about their family history. When you do counsel women as to whether they should be referred for consideration in anastrozole, it's important that you talk a bit about side effects, and there are 2 key areas to talk about. The first is osteoporosis. We all, of course, know that loss of estrogen following the menopause is associated with reduction in bone mineral density and an increased risk of osteoporotic fractures. Use of aromatase inhibitors, unsurprisingly, since you're further suppressing estrogen, seems to be associated with a 2 to 4-fold increase in this bone loss. 5 years of treatment with an aromatase inhibitor is associated with an absolute fracture risk of about 10%. For this reason, if you do have a woman who's going to take an anastrozole, it's important that she has a bone health assessment involving a FRAX score and a DEXA scan if this is indicated, and consideration of appropriate therapy if needed. The more immediate side effects that your patients may experience, however, is worsening menopausal symptoms. And of course, if you suppress any further estrogen that they're making, then you're going to get a worsening of hot flushes or urogenital atrophy or any other of the common menopausal symptoms we see day in, day out. As you're trying to suppress estrogen production, HRT is not an option to treat these, unfortunately. So you're going to have to use non-HRT options such as SSRIs or gabapentinoids or vaginal lubricants. It's an important thing to balance the tolerability of these symptoms against the benefit of using anastrozole. And of course, what one woman experiences is going to be completely different from another woman. So unfortunately, there's not much you can really do apart from try and see. I would, however, make sure you counsel women on this potential side effect before you refer them. Is it something they may wish to consider before they're seen in clinic? If you do have someone who's interested in starting anastrozole, what should you do? Now, in most areas, in fact, I think in all areas, anastrozole remains an amber drug, so it's not something I would start directly in primary care. However, I had a woman who I thought did fit into one of the aforementioned higher risk groups of breast cancer, and they were interested in reducing that risk through taking anastrozole. I certainly would offer them a referral to a secondary care breast clinic, and if the specialist in that clinic deemed it appropriate, then I'd be absolutely happy to prescribe anastrozole. Of course, we may find after this initiation of treatment that side effects rear their head, in which case it would need a rediscussion and a risk-benefit analysis between you and the patient to decide whether that was an appropriate treatment for them in the long term. This concludes this video. I hope it's been useful. The few references I've used are all listed below. Any comments or questions, please send to me at this email address, and thank you again for watching.